Your depiction of where we are and where we're going to be in 3 years, 5 years, 10 years is remarkably exciting. And I think your analogy to the phone is exactly the right. Bob and I were probably thinking back to our first days when we were taking calls for Gusto calls, exactly. And we were carrying around a phone that was pretty darn heavy in a bag. And now to think about on the way here to try to get around the traffic in San Francisco, we were using our cell phone to find various ways and where every single car on the side of the road was marked on the technology that was telling me which way to go at which moment.
By the way, 10 years ago, the iPhone did not exist. Most people don't realize that. 10 years ago today, the iPhone did not exist.
So no one in San Francisco needs to be told technology is going to move and the world's going to change a lot. I love the fact that you chose your examples predominantly around cardiovascular disease, which in our minds has been at the cutting edge of a lot of new technology, be it stents, be it in the medicines that we use. So to think of us on the verge of a new era of medicine that is using the technology you're talking about is quite exciting, and I know for the Heart Association, leading that charge is pretty darn exciting. I guess my question, though, is, when we're talking about using that technology to monitor people 24/7, we're thinking about using that technology to make decisions and help to guide where we're going. It implies, in part, that there is a partnership between people like yourself, who are both on the side of consumers of healthcare, and also people like Dr. Harrington here, who is actually having to deliver healthcare. And that's in part what this conference is about, and I think in part where the first question is. How do these two worlds meet up? And maybe, Bob, why don't you sort of describe a little bit of your first thoughts here?
Well, first, Vinod, thank you for being here tonight. It's a privilege to hear your thoughts on the topic. The thing that first goes through my mind is I wish Epic were a public company so you could buy it and fix it, because it's a disaster for the reason that you've pointed out. It's interesting, if you ask doctors about the electronic health record, there's been a lot written about the misery it caused. But if you also ask doctors, would you want to go back to a world without the electronic health record, they uniformly say no. Because we all recognize the power in being able to aggregate information and to be able to, as you've said, make decisions based on that information. To me, there's been sort of two fundamental flaws in the way that a lot of health technology has developed. It's either been developed by technologists who don't necessarily understand the clinical imperative, or it's been developed by clinicians who have a good idea but who have no sense of technology. Yeah. And somehow, and I like the fact that the AHA has brought a lot of us together for this, we need to merge those two worlds so that we can both learn from each other what the issues are and move it forward. I like to say that as a physician, there's only two types of decisions I should ever make. One is that the answer is known, and as you say, you can get that answer quickly. And if the answer is known, the system should just do it for me. Mm-hmm. Aspirin after a heart attack maybe is a good example. The other is when you don't know the answer, and the system should force me to study it and engage me in the study of it. And we're not perfect in either one of those yet. So I'd love to be in a world where those two things are coming together.
And they are coming together. In fact, there's two companies I can mention that are essentially doing this. Lumiata probably has 60 million medical records, and for your condition, it finds the closest patients. And the way they're approaching the physician adaptation problem is interesting. The way they're going to present it is go to insurance companies and say, pre-approve the best outcome, right? And the others, the doctor has to do this extra work to justify, so they're not taking choice away, but saying, here's one pre-approved one, and they provide clinical rationale. So they say, here's the rationale for this decision. There's other decisions other physicians have made out of those 60 million medical records, and you can provide rationale for it. By the way, if you have good rationale, their system learns additional rationale. So the more it gets used, the better it gets. But the doctors, of course, will tend to pick the path that the insurance companies will pre-approve, so you're taking advantage of a bad thing, which is the insurance approval cycle.
So it's interesting. As I flew out on the plane, I'm having to do my recertification for boards, which is going to happen next week, and hopefully you'll hear that I'm recertified by the end of the week. Else my days as a cardiologist may be very short-lived. But as I sat on the plane, I studied facts like Noonan syndrome is associated with pulmonary valve stenosis. And I'm thinking, why am I relearning all these facts?
That's exactly right.
When, in fact, they could be in a database. If I had a patient, I've never had one, but assuming I would have a patient someday with Noonan syndrome, I should be able to have a computer prompt me to say, by the way, you might want to think how their pulmonary valves are doing. But yet, we relearn these facts every 10 years, in part to recertify as a cardiologist. Yet there's a lot of other skills, potentially as me as a cardiologist, that maybe I should be tested on, but I'm not.
But I think that's Vinod's point. I think that
Yeah.
we absolutely have to get to a system of medicine where we think that way. You know, one of yours and my favorite people in medicine, Gene Stead, thought of this stuff in the 70s, right? And one of Dr. Stead's famous quotes is, never teach anything that you can look up. And he said this in the 60s and 70s. Right. And what he meant by that...
Before Google.
Way before Google. But
Right.
what he meant by that is that what you should be teaching people is a way of learning. And a way of learning is to be a sophisticated user of technology so that you can learn. I mean, learning about Noonan system, I passed the boards last year, so don't feel stressed. Right? But...
Sort of am, but that's okay.
But what a waste of time.
Right.
And why are we allowing the system to dictate that that's how we're going to do it? It's just a waste of time.
By the way, my cell phone did tell me I was a little depressed on the way out here, so I think one of the programs was working quite well.
So let me make a comment on this. This is really important. Absolutely anything you can access, and most facts you can access now on Google. 10 years down the road, you'll be able to not only access all those facts, but do complex logic on it. If you have this, but you happen to have low blood pressure, and you're more than 70 years old, and if you have 3 comorbidities that are serious, then go for a stent. Otherwise, if you're looking for a 30-year optimization because you're otherwise healthy, go for cabbage. Right? That is complex logic on essentially facts you can look up. That's the next generation, where this complex logical scenario gets subject to the same kind of decision making, so you don't have to. One of the most interesting questions is, what is the role of the human then? And we know a patient, and you could say that for a doctor too, but the patient isn't a rational being. He's an emotional, he or she is an emotional being first. We know because the placebo effect works, that things aren't rational. Love and sport, as Dr. Dean Ornish would say, actually change the outcomes. To what degree, different people may do. So the role for the human may actually change dramatically from specialist, and this is what I was referring to, this integrative, confidence-giving person that maybe serves a very, very different role. I'm intrigued by what that role might be, and if you're completely free to essentially just interact with the patient, what would you spend your time doing? It's
right. It is interesting, though, and in part, I remember back now to my earliest days in medical school at Pittsburgh, you mentioned there. Jack Myers in those days was one of the first in the idea of using sort of this computer technology to make Caduceus, which was a decision support tool that was supposed to revolutionize medicine. Didn't happen. We lived through the Duke Databank days where we had predictive algorithms that were helpful to help decide who should get bypass surgery, who should get medical therapy, etc. Those came and unfortunately even went at our own institution, only to be now rethought about once again now 20 or 30 years after they were first invented. So I would, on the one hand, I think that absolutely the technology is there, but are we as a field going to be in a position to be ready this time through to adopt? In part, you've given me some solace, though. Your idea that first generations of things sometimes are clunky and are sometimes not accepted. Great ideas sometimes take 20 and 30 years to be accepted by the humans around them who have their own challenges.
I had an interesting meeting yesterday with our chair of pathology, who is going to go through the process of getting rid of slides and digitizing everything. And his estimation is that 80 to 85% of what pathologists do could very quickly be read by a machine and identify patterns better than the pathologists probably do reliably.
There's plenty of research to indicate that's true.
That's true.
Andy Beck at Harvard has proven that you can read much more than a pathologist could out of the same. He was dealing with cancer pathology.
And more reliably.
And more reliably. We know in radiology that's also true.
And then the question is, when you ask what a doctor is going to do, he believes it's the other 15, 20% where the machine's not ready yet to read it, that there's still some need for the expert interpretation, and then, but even that at some point will go away.
Yeah. Look, a good analogy is in the 1930s, as soon as flying airplanes got complex, the number of crashes went through the roof because of the complexity, and autopilots came to be. The humans really only intervene in flying from here to New York in exceptional circumstances. Otherwise, autopilots do almost all the flying. We haven't gotten rid of the pilots. I'll give you another piece of data which is very, very intriguing. The best computer program in the world easily beats at chess the best human. But a mediocre computer program with a decent chess player can beat any computer, which is interesting. Now, will cardiology or medicine be like that or something different? I don't know the answer. I'll give you another amazing statistic because these are really critical to how these systems evolve. AlphaGo, which Google used to play Go, stunningly sophisticated AI. It's the first system where essentially the system developed what could only be described as great intuition. Lee Sedol, who was the world champion, played the computer, was confident he'd win. He lost badly. Prior to this game with the computer, he was winning 75% of his matches against other humans. After this, and after studying what the computer did, he's now winning 90% of his matches against other humans. So he's become that much better. How that happens in cardiology or other fields, it's a little hard to speculate, but there are indicators that these systems will make us better, and there will be exceptions where we need them.
Because we'll learn from machines.
We'll learn from them.
So you're imagining that the next generation to replace Bob's favorite Epic will be somebody that will compete on not the ability to better bill, but on the ability to better diagnose and use the data that lives within their own system?
Oh, it's going to be the computational end, for sure. That's where the magic is going to happen, not on the entry level. I mean, that's the problem with Epic, right? All the energy is in the entry level, and the computational part of it is terrible.
Let me give you a simple example, something I'm dying to build one of these days. If a patient walks in the doctor's office, fills out that little form and pen that's just stuck away somewhere that nobody ever actually looks at. In asking those questions, if you could dynamically adjust the questions, so you came in with, say, a bad cough, it could easily adapt to asking the questions that eliminated either strep throat or something even more serious by 3 or 4 additional questions. You can almost finish the diagnosis by just having them enter their condition and exclude possibilities, especially the rare possibilities which are almost always missed early because physicians don't run into them very often. So you're not going to look for Ebola if a typical patient comes in, or Zika. It's very interesting to speculate how those systems actually finish the diagnosis before the doctor's seen them and help the doctor include rarer conditions that may be more serious or exclude them. Those are really interesting human design interaction possibilities.
People are actually developing for emergency medicine physicians those sorts of symptoms, those sort of systems where based on key symptoms, creating a differential and quickly going down, just in a way that you've said. So you're absolutely right. It's on the right.
And the first simplest version is in an emergency room is to do triage, because that's the most critical short-term decision when somebody walks in the door at an emergency room is triage.
Right. Is it really bad, or can I think about it?
Yeah.
So we've decided that in 10 years, my boards will be passed by my partner next to me, sitting, which will be good. This will be good. I can get through. Now let's move on to sort of a second concept that you brought up, which is the monitored self, and the discussions about where both technologies are going, but also perhaps how people are going to use it. I guess the question I have, and you brought up even the AliveCore example where somebody's taking a bunch of EKGs every week, is the potential for who's both adopting these technologies and then potential maybe even use, but also misuse or challenges that come from that technology. The monitored self in certain ways has created perhaps the most likely to adopt it are the worried well, as opposed to those who may have illness and or the digital divide that exists for certain groups across America. Thoughts on those topics?
You know, I generally view technology as a tool. It can be used for good or bad. It can be used well or poorly. Nuclear weapons is obviously the most important. You can use it for nuclear power or nuclear weapons. Technology doesn't have a value system. So it depends on us humans to decide how to use it well. You know, take AliveCore. If at every AFib episode it shows up on a doctor's dashboard, they call you in and say, hey, I now have a billable event, that's not very good. On the flip side, because they're seeing tens of thousands or hundreds of thousands of AFib events a month, if they can differentiate further beyond AFib, what's harmful AFib and what might have negative consequences or trending the bad way, or what, you know, yes, it's AFib, but there's a simple at-home, take it easy kind of. I think we will have that information once we have, say, 1 million AFib events and the right data science associated with that. How we use it, whether we use it to increase billing or keep the patient at home, and then if they're really at risk of a stroke or some other event, we call them in, and we can predict hours in advance. Maybe we know what to do about it. Those are choices that we will have. They're incentive systems. Are you a cost-based system like Kaiser, which doesn't want to increase costs, or paper service? Incentives will determine how technology is used. It's sort of the bottom line.
I mean, so I know that Mintu Taraki is going to talk tomorrow about evaluating technology, including, I suspect he's going to talk about some of the arrhythmia monitoring and how one uses that and tests it for what actually is the value add, because that's the big question, right? And I think that's what you're getting at. Let me turn it, Eric, to something that you think a lot about, which is blood pressure. And the big controversy that came up over the SPRINT trial, which was a trial that basically showed that lowering blood pressure a little more was better than lowering it not so little. Right. And pretty simple question, but great controversy over, well, did they actually measure blood pressure in a way that's consistent with practice? In some ways, who cares? They showed that lower was better than higher. But I'm of the mindset that why can't we live in a world where we get hundreds of blood pressure measurements and then on a patient and then figure out what actually is good blood pressure?
Right. No,
but we're not there yet.
Yeah, no, and we'll talk about.
And this is important because today, when you take blood pressure at home or in the hospital, you have a few data points, right? So AliveCore just introduced a relationship with Omron, where their meter automatically feeds the AliveCore app. If you have hundreds and hundreds of data points per patient, you suddenly start to get intelligent. Now, the studies that you're talking about are generally done with 300 or 3,000 patients. I don't know how big this
is tens of thousands, yeah.
Okay. But if you're talking about millions of patients,
yeah.
it's very hard to fool the system. Real data comes out. And you avoid some of the problems of data, which is overfitting data, and I don't want to go too much into the technical details, but you see that so often in studies because the sample sets are so small and overfitting becomes easy, and that's why you have conflicting studies. One says one thing and another says something else. It's because of data overfitting.
So you're not going to get any argue for two people argued for very large trials through much of their lives. I think we'll support you there. I think also the point of continuous monitoring versus episodic is certainly continuous is going to be better. And the ability to sort of see how somebody responds in their own home environment versus how they sit in an office after they sat for X number of minutes in a darkened room with somebody monitoring one set of blood pressure cuffs.
Oh, it's got to be a lot more informative. Right. We just don't know yet what to do with it, though.
Let alone the idea that even on the response side, I mean, once we even diagnose high blood pressure, the idea of seeing how do you respond to that blood pressure early in the morning versus later in the afternoon? How do you do it if you miss a dose? Could you get that feedback that you, lo and behold, missed the dose and your blood pressure is now high today? Good feedback system that would be important for that patient to have. And those technologies to do that, although they're getting better and better and smaller and more continuous in nature, even just the blood pressure cuffs connected to a phone, as you've already indicated, or other forms, are ways in which that technology could actually reach doctors in real time. Which brings us to the next problem, which is the degree to which now you link these new technologies and new monitoring systems to health systems in a way that will actually gain value on both sides. And that's where the challenge exists.
Well, that's the concept that the IOM talks about with the learning healthcare system, is that we've got to get to a point where, I think Vinod is exactly right. We don't need, what is it now? It takes 17 years to actually change medical practice. We need 2-3 years. And the only way we're going to do that is if the learning is built into the system, so that if we get hundreds of thousands of blood pressures coming into our system, we're learning from that and we're adapting. But in many ways, you've got to take the human being out of that in order to get the system to adapt.
So we'll talk about this tomorrow in another example, but there was actually a good study, a randomized comparative trial looking at Fitbits and how they might help with weight loss. Everybody thinks that if you have a monitor and get feedback, you would get better weight loss than if you didn't. In the study that was carried out and published in JAMA just a week or so ago, the results actually were counterintuitive, where the actual technology showed less weight loss than in the side that didn't. Kind of hard to explain exactly why they got worse results, but in response to that, the comments were made that this was old technology, and the critics were absolutely right. This was probably 2 or 3 year old technology, and as Mr. Khosla points out, that cycle within this field is 2 or 3 generations behind where the best and latest is. So part of our challenge, both as medical doctors but also as researchers, are can we develop systems that will keep up with the evolving technology?
No, it is intriguing. First thing I'd say is studies are confusing. If you didn't get weight loss, why did you not? Well, people who exercise more generally actually don't lose weight. It's just conversion of fat to muscle mass. Is that what's going on? I don't know the answer. Right? So you have to ask the next level of question. That's one point. The other point I'd make is, and I tried to sort of briefly touch on it, as these systems get much more responsive and adaptive and consumers use them, I think it will change the rate at which medical practice changes. So the 17-year number is often talked about, but let me give you a counter-example. As soon as patients started looking on Google or Wikipedia for their conditions, it took probably a few years for Wikipedia to become the most consulted medical resource. Why? Because patients walked in with their Wikipedia page about their condition, and doctors didn't want to be embarrassed, so they read that page. I'm saying patients can force behavior change, and much better informed patients will increase the rate at which doctors adapt to new knowledge. I'm very, very bullish, and that pressure will come from patients doing Q&A with systems. And today, WebMD is a pretty archaic system. That will become much better. And I'm very optimistic that will then drive doctors to be much more responsive to changes in practice, changes in knowledge, new studies, and I'm excited about that.
I think that's true even if you watch our trainees. When you know, it used to be that you'd make rounds with your trainees and you'd say, well, I think that was in circulation and, 5 years ago. And now, before you open your mouth, they give you a full literature review because they're sitting there on the computer.
Yeah.
And so it has changed. It's changed the way you teach. It changes the way you interact. We look things up constantly as we're walking through the hospital in ways that we never did before. You're absolutely right.
Is there questions from the audience?
There's a microphone here coming.
Thanks. First of all, that was very inspiring. I really enjoyed hearing this. It was great. I have a silly question and a real question. The silly question is, it says Fireside Chat, and I wondered, is this a video of a fire or is it a teleprompter?
We got the Yule log going there.
So the serious question, though, is a first-year engineering student would tell you, if you want to control something, you have to measure a parameter that tells you, are you controlling it? So blood pressure, maybe. And you have to act faster than the system you're trying to control. That's basic control theory. So if you're trying to build a car that would stay in the middle of a lane and drive itself, you probably wouldn't see it once a year and give it a dose of something and say, keep taking that and check in a year, right? So we're not doing it right, and I think it's not just what you measure or how often you measure, but the whole loop. You measure the right thing, you act fast enough, and you adjust the right parameter. So I think there's a long way to go, but the mindset you guys established tonight is really, like I said, it's inspiring. I really appreciate it. So I guess that's sort of an open question or begging for a response.
Well, this gets to Vinod's comment about aligning incentives. And unfortunately, the American healthcare system has been predominantly this fee-for-service thing. So what do you want? You want people to come back and see you to adjust their blood pressure medicine. As we move more towards accountable care, what we ought to be doing is caring for a population. And so the incentive then becomes not to have you come see me, but to help you figure out your blood pressure in the context of your life. And for me to help manage, or not even me, for the system to help manage your blood pressure in the context of what you're doing all the time. And I think we are moving that way, and some health systems, Kaiser's a great example, Intermountain in Utah is another great example, are making big strides towards that. I mean, Kaiser has now, what, Eric, 80% blood pressure control?
Yeah, no, it's amazing what can be done. The other thing I would link to this is that, we talked about the redundancies and parts that sort of physicians don't have to do anymore, and in fact would do better if machines did it for you. It's kind of, if you really want to push this envelope, and I don't know how far we want to go, but if you look at actually the taking of medicines, which I struggle to do when I now am on my own statin every morning, and did I remember to take my statin today? Which is kind of an embarrassing sign of my times. But should I have to remember that? Or should there just be a little implantable in me that will release a certain dose of my favorite statin for the day? And yet, osmotic pumps are coming out soon that will probably allow lots of the medicines that we take on a routine basis to be distributed, even not in bolus form, but now in a continuous fashion throughout the day without me ever thinking about it.
Well, lots of possibilities there. There's sort of, I saw an interesting startup. If you're taking 4 different medications, they actually custom 3D print one pill for you. So there's all sorts of possibilities. But there's an important element to this question. A friend of mine at UC San Diego, Dr. Larry Smart, decided about 10 years ago to do weekly testing on about, I think it's 30 or 50 variables he measures. And he found a couple of the numbers going off kilter about 3 or 4 years ago. He went to his doctor and said, hey, these numbers are shifting. And I forget which variables, but they were pretty normal blood tests. And the doctor said, how do you feel? And he said, great. He said, well, don't worry about it. He discovered his biomarkers detected his IBD 2 years before it was diagnosed in a traditional medical practice. Retrospectively, if you'd done that with thousands of people, you'd be able to detect it early. And he found then, over the course of the last few years, that the probiotics dramatically shifted how bad or good it got. That is an example of measuring variables. I happen to measure 1,200 variables, a metabolome test every quarter. I do a full microbiome test. I do probably 500 other variables every quarter. I'm only doing it to see how much they shift. But frankly, I'd like to see 1 million people do it so we know what's statistically valid. I can't, from a sample of one, say what's valid. It's still nice to know what happens to me between age 60 and 70. And I wish I started it when I was 30, and my son's doing it now. He's in his 20s. We start to measure. But measuring all that will change medical practice proactively and dramatically. And these numbers will tell a story way before symptoms appear or things get worse. And I'm very, very optimistic of the following fact. And most people have a hard time believing it. Most people say every time you have great technology, it increases medical costs, and it's a constant argument. And yes, with proton beam accelerators, that does happen. But if we decide that every person should measure 300 variables every week, I'm almost certain the cost of that test will get to $300 a year. Why? Because you couldn't do that with a venous blood draw. So you suddenly have to do it off a finger prick. It suddenly starts to look like a diabetic finger prick test. And I know Theranos is being discredited. We have nothing to do with Theranos. Those technologies would show up if that was practiced. They haven't shown up because they aren't practiced. So a metabolome test is a mass spec, and it's, I think, $500–700 to get my quarterly blood test, which to me is totally worth it, given everything. But measuring is important, and I think measuring more will change practice, which will then change the cost of providing that service. There's no question a blood draw and blood transport cost more than any of these tests themselves.
Yeah, I mean, some of you in the crowd probably know Mike Snyder at Stanford, the chief chair of genetics, who wrote a very well-cited paper now where he measured everything on himself for several years and detected prediabetes.
Yeah.
And then embarked. And you can always tell Mike on campus because he's got sensors all over him as he
So I'm patient number 2 in his all-omics study. My daughter's patient number 3.
There we go.
So I subscribe to all data gathering.
So that's only 900,000, more to go, and we'll have our 1 million. There was another question out? Yeah.
Go ahead. Thanks. Mike McConnell. So a lot of this brings up one of the criticisms of technology in healthcare, which is that it's increasing disparities in care, right? We have a significant portion of the population here who aren't getting even sometimes the most basic care, and we're talking about very advanced care. On the other hand, you could argue that, cell phones and mobile phones have been disseminated throughout the world in a fairly rapid time frame. How do we try to make sure that when we're talking about all this advanced technology that we're trying to keep in mind how to scale it so that we can really distribute it to, our U.S. or world population and not increase health disparities in the process?
So I'll actually start that. I think you're right to worry about it, but the answer may be counterintuitive. So we think about the fact that technology innovation will then benefit the wealthy and leave the others behind. But in almost every way, as technology comes into a society, it tends to flatten out the differences that exist in the world and give many people who didn't have chances better chances. Think about even cell phones as one example where basically become ubiquitous. and in part have allowed a lot more technology and applications and even access to internet and services that were never possible in the past. Go to Africa where they can do banking on cell phones, which would never have happened. But now you take it to the world of healthcare, and we'll use the blood pressure example as just one. If you had, if you're wealthy and you can take days off your work and go in to see your private doctor and have him monitor your blood pressure, and you can come in as many times as you want because you're one of his VIP patients, life is good. Now you work in a job where if you miss your hours of day, you miss your pay for the day. And now how much encouragement do you have to get your blood pressure monitored? Where you go and you sit in my office for an hour or two to get one measurement of blood pressure so I can tell you to change a medicine, which I should have been able to monitor from your own home and call that medicine in. So you can imagine in a new world, monitoring blood pressure and would be a lot easier for the disparate population and probably less attractive to the rich, who will still get their monitored by Dr. Harrington in his office.
I had another question.
I'd add one or two things to it. I jokingly say, I hope in 15 or 20 years, I get better medical care at a village in India than I get at Stanford, because Stanford will still have experts and humans. Right? It is counterintuitive, but in fact, it's very likely. Now, you have to get a little bit nuanced. If I'm talking about diagnosis or prescription or monitoring, almost certainly the best technology best care will be delivered by machines. And I'm much more likely to get better care when there's no humans with their biases in the loop. Dr. Ioannidis at Stanford, one of my favorite researchers, who talks about all the biases in medicine and the sources of error in medicine. Now, if you're talking about procedural medicine, so you're not likely to get better procedural medicine at a village in India. I still want to go to Stanford for that. So it is nuanced, and it will vary by specialty and category, but it will also depend on how much we let machines take over and have humans serve the right role. Already it's clear, even at the very early days of driverless cars, Tesla's having fewer accidents per mile driven than human drivers. Now, we're not comfortable letting that take over, and we're probably not even ready for it. But people speculate that within some period of time, like 15 years, humans may be banned from driving. The question is, will doctors be banned from diagnosing?
Good quote for the day.
Interesting way to end.
He's going to tweet that one out. I know it's coming. Last question.
My name is Taha Jagdam with Redox, an integration engine for EHRs. I had a couple questions, and you actually transitioned into it perfectly about clinical decision support platforms. In the beginning, a lot of it, the whole time I was thinking, this is simple. It's CDS. Outside of, Epic's CDS platform, where are we in terms of adoption of clinical decision support platforms? And then my follow-on in that is, as you're training residents or fellows, a lot of times in medical school, I won't say where, I was always instructed, CDSs aren't really going to be that beneficial compared to you yourself. And then my second question was, and you also transitioned into it, was as far as patients owning data. So for a lot of people, when they come from outside of healthcare, it makes logical sense to think that a patient should own their own data simply because they're consumers. But as consumers of healthcare services, where are we in terms of patients owning their own data and being able to research it and able to facilitate better practices? Sorry for the long question.
So I think clinical data support it was in its infancy years ago, and it wasn't very good. It was a little clunky. It was that earlier generation that Vinod and Eric were talking about. But it's getting so much better. And there are systems, Intermountain is a great example, where Brent James talks about this notion of 85% of what you do, the machine can take care of. We want to save you for the other 15% and for doing procedures, et cetera. So there are systems, there are examples of doing it. it's an institutional bias. I mean, there are people, I have people in my faculty who say, well, I don't need guidelines, I know what to do. I don't want to go to that doctor. I want to go to the doctor who says, I'm going to follow the guidelines, and why wouldn't the machine just help me do that? And let me spend time with the patient figuring out, well, why don't you take your medicines? What's going on in your life, et cetera? That's the human element piece of it. In terms of the training piece, I think that the trainees today are a lot more sophisticated. They're a lot more quantitatively inclined than they were in our generation. I think they are adopting these a lot more readily.
Do you feel Watson's a good example of kind of that CDS tool?
I've not. Watson's used at Duke, isn't it? Or?
No.
Oh, it's not been used at our place. I don't know enough about it as a technology to say that, other than watching it on Jeopardy.
So let me speak to this. I've spent a fair amount of time looking at clinical decision support systems. Most of them in the past were fairly poor. Take one of the best known, De-Explain, out of MGH, right? It is about 30,000 handcrafted rules today, collected over 20 years of practice. There's a problem with that. When you enter rules over 20 years, and there's 30,000 rules, many of them are conflicting with each other. Two, when a new paper comes out, new piece of research, you're waiting for somebody to turn it into a rule, and almost certainly when they turn it into a rule, they're not going to check against the existing 30,000 to see where the conflicts are. A great example that I've covered elsewhere is beta blockers in perfusion therapy, two things that were independently verified, but together they're a disaster. I just sent an email to Dr. Boyd, and he was surprised. For non-cardiac surgery, if you had perfusion therapy, then beta blockers before other surgery increase your risk of mortality 37%. But these are conflicting rules. They came up in different eras because the technology came in different eras. So things like MGH's system are really poor. Watson's a slightly more sophisticated rules system, and it's probably equally fragile. About a week and a half ago, I had a detailed conversation on Watson oncology with the folks at MS Memorial Sloan Kettering. It doesn't work for the following reason. As new things come up, these rules aren't automatic, and they aren't checked against everything else, and only a completely machine-run system can do this well. And that doesn't exist today, that as far as I know. What some of the recent systems have done, we have a company called Lumiata that's doing this, is essentially statistical rule generation. And that's better. And they started the following way, and this is sort of interesting. They started by taking all the literature, analyzing it, making rules out of literature. Then they took tens of thousands of physician hours to curate the rules by hand. And they found that was a complete disaster because they introduced kinds of contradictions that you didn't want in your rule set. The thing is, they used that then to get access to medical records, made a clinical decision system that I was talking about. They're introducing through the payer, through the insurer, or whoever's at risk. Those systems are better. But the real system that uses the kind of intuition I was talking about in AlphaGo and can compute logic on these factual studies, that's yet to come. It's sort of one of my dreams. We'll see it in the next 5 to 10 years. It's doable today. Nobody's doing it well, mostly because the people who can do it don't have access to all the data.
So I'd like to thank you both. I spent the other part of when I wasn't studying for the boards, the second part of my time was actually helping my son with his medical school applications. And I had this great debate about, on the plane, whether or not my son should actually be pursuing this career. After this session, it's become clear to me that his world will be as exciting or perhaps even more exciting than the medicine that Bob and I practice. We've had the opportunity to see where innovation is going and the vision of a future empowered and not threatened, but more empowered, where both patients and individuals, as well as clinicians and health systems, will use data to drive better health. This is a remarkable kickoff for this conference. It's not the end, but the beginning of a very exciting day. Thank you very much.
Thanks, Robert.